Des commentaires des médecins et
we'll
ensuite on
start
prendra des questions
first with
téléphoniques.
comments from the
Tam,
doctors, and then we'll go to the phones.
Merci beaucoup. Thank you. And hello, everyone. Bonjour à tous. Today, we'll provide the latest update on the national epidemiology and modeling work that informs the ongoing management of COVID-19 in Canada. Coming out of the holiday season, we're seeing how quickly Omicron has changed the landscape of the epidemic in Canada. In just a few short weeks, Omicron has spread faster and further than any previous variant. At the same time, we're seeing Canadians rise and adapt to the latest challenges by updating their vaccine protection, improving their mask quality and fit, and keeping up with multiple other layers of protection to reduce their risk of exposure and spreading the virus. Public health has also had to adapt in the face of the explosive spread of Omicron cases that has exceeded the testing capacity in many areas of the country. Although some of our earlier indicators, like daily case counts, are now strikingly high, while at the same time significantly underestimating the true number of new infections. This update puts more emphasis on some of the many other indicators that continue to be useful for monitoring current trends and predicting longer-range trajectories.
Bonjour à toutes et à tous. Aujourd'hui, nous ferons le point sur les travaux d'épidémiologie et de modélisation effectués au pays qui orientent la gestion continue.
Coming out of the holiday season, we're seeing how quickly Omicron has changed the landscape of the pandemic in Canada. In just a few short weeks, Omicron has spread faster and further than any previous variant. At the same time, we're seeing Canadians rise and adapt to the latest challenges by updating their vaccine protection, improving their mask quality and fit, and by keeping up multiple layers of protection to reduce their risk of exposure and spreading the virus. Public health has also had to adapt in the face of the explosive spread of Omicron cases that has exceeded testing capacity in many areas of the country. Although some of our earlier indicators, like daily case counts, are now strikingly high, while at the same time significantly underestimating the true number of new infections, this update puts more emphasis on some of the many other indicators that continue to be useful for monitoring current trends and predicting longer-range trajectories.
Since the last epidemiology and modeling update in December, despite being underestimated, current national case counts of over 37,500 new cases reported daily are far exceeding all previous peaks of the pandemic. The sudden spike in Omicron infections has daily case counts now trending far above the daily counts for severe outcomes. And while international surveillance shows that severity trends do not rise at the same explosive rate as cases, the record high volume of cases associated with the Omicron surge is nevertheless expected to heavily impact hospitals. Although there are likely to be continued challenges before we hope to see improvement, caution and perseverance will help to get us through this difficult period sooner and mitigate the impacts on our severely strained health system.
Diapositive 2.
Slide 2. With very high infection rates that are challenging or exceeding testing capacity across much of the country, a range of other indicators, such as laboratory test positivity, are useful for monitoring disease activity at the population level. Currently, laboratory test positivity is 28%, meaning more than 1 in 4 tests are positive for the virus. Although many jurisdictions have prioritized testing to individuals and populations at higher risk of severe outcomes or exposure, the very high positivity rate shows that COVID-19 is widespread and that case counts underestimate the true burden of infection in the broader population. Nevertheless, tracking the trend of this indicator can help tell us whether COVID-19 disease activity remains widespread or is beginning to decline in areas of the country. At the same time, other indicators continue to be used in parallel to monitor other aspects, including patterns of disease severity.
Slide 3. That Omicron is the most contagious variant observed to date is evident from these curves, showing the sudden increase in the proportion of cases due to Omicron shown by the red curve on the right. First reported in Canada in late November, Omicron has rapidly replaced Delta to become the predominant variant circulating in Canada as of mid-December.
Diapositive.
Slide 4. Hospitalization trends rising or expected to rise given record high infection rates due to Omicron. Hospitalization trends are shown for Canada's 6 most populous provinces, but unlike previous waves of the pandemic, when disease spread was generally well controlled in some smaller jurisdictions, the Omicron surge is widespread across the country. Although evidence shows that the risk of hospitalization is lower for Omicron compared to Delta, severe illness does occur with Omicron, and the impact on the health system and other sectors can be substantial. This is due to increased hospital and critical care admissions, as well as increased staff illness and isolation. Already, the enormous volume of cases is driving an increase in severe illness trends nationally. These increases are most evident in Ontario and Quebec, which were the first to experience the Omicron surge, but most areas of the country are starting or expecting to see heavy increases in daily hospital numbers over the coming weeks. Since our last update, the number of people with COVID-19 being treated in our hospitals has more than quadrupled to an average of over 6,779 daily, while the number of people in critical care has doubled to an average of over 884 daily cases, and 82 deaths were being reported daily. Keeping infection rates down maintains key to mitigating the rise in severe illness trends as much as possible over the coming weeks.
Slide 5. The incidence of reported cases is higher across all age groups than at any time previously during the pandemic, as opposed to previous weeks when rates were highest among 5 to 11-year-olds who were just becoming eligible for vaccination. Incidence rates are currently highest among adults aged 20 to 39 years. With Omicron's greater ability to evade prior immunity from infection and vaccines, cases are now increasing in all age groups.
Diapositive.
Slide 6. While the overall volume of cases is driving an increase in hospitalization rates across all age groups, the age distribution of cases in hospitals is similar to previous waves of the pandemic, with highest hospitalization rates observed among older Canadians. Over the past month, severe outcomes, including the number of hospital and ICU admissions, have been highest among adults 60 years of age or older, and particularly among those aged 80 and older. Ultimately, the population-level impact will depend on the overall number of cases leading to more severe illness. So everything we can do to slow the spread helps to mitigate individual and overall impacts. Among younger age groups, cases in infants aged under 1 year are almost 7 times more likely to be hospitalized than children aged 1 to 4 years. But while hospitalization numbers have increased among children compared to previous waves, they remain low overall, comprising less than 1% of total all reported cases in children under 5 years of age. Fortunately, among children, there continues to be low rates of intensive care admission. Nevertheless, by keeping infection rates as low as possible, we can reduce more severe illness among children.
Omicron's rapid rate of spread is likely due to a combination of inherent characteristics of the virus that makes it more transmissible and increased ability to evade prior immunity from past infection and vaccination. Similarly, Omicron's lower severity profile, as seen in international and Canadian data, is likely due to characteristics of the virus and protection from severe disease as a result of vaccination and/or prior infection. This is supported by the fact that those with 2 doses of vaccine are less likely to be admitted to hospital, and this protection is increased with an additional mRNA vaccine dose of either Moderna or Pfizer COVID-19 vaccines. While considerably lower proportion of Omicron cases are being hospitalized compared to Delta, severe illness does occur with Omicron, and the impact on the health system and other sectors is expected to be substantial. Hence, vaccination, including getting an mRNA booster dose as eligible, continues to be important in combination with timed and targeted public health measures and individual protective practices for slowing COVID-19 infection rates and help to reduce impact on healthcare capacity. As well, despite a high number of outbreaks being reported in long-term care homes and seniors' residences, preliminary evidence indicates that these outbreaks are associated with less severe illness and the number of deaths remains low. However, as seen with hospital outbreaks, these outbreaks can involve a high number of cases among staff, which is contributing to reduced staffing levels.
Slide 8. Overall, more than 72 million doses of COVID-19 vaccines have been administered across Canada since vaccination began in mid-December 2020. However, while Canadians aged 12 years or older have over 83% vaccine coverage with at least 2 doses, coverage is lower among 5 to 11-year-olds who more recently became eligible for vaccination, with 48% having at least 1 dose. All told, there are currently more than 6.5 million Canadians who are eligible but are not yet vaccinated or have less than 2 doses of COVID-19 vaccines.
Slide 9. In terms of additional doses, 11 million COVID-19 vaccines 3rd doses have been given, the majority of which are booster doses. While we are making progress in updating protection for those in higher risk groups, including older adults, we need to continue efforts to increase vaccine coverage to enhance protection for everyone we can. As seen in this chart, a considerable proportion of Canadians who have received at least 2 doses still need an additional dose to restore protection that may have waned since completing their primary series.
Slide 10. Being fully vaccinated with at least 2 doses continues to provide good protection from severe illness requiring hospitalization. In this chart, the shape of the curve of hospitalized cases among unvaccinated people closely aligns with overall incidence of hospitalization during the rise and fall of the Delta-driven wave and heading into the Omicron surge. Conversely, the hospitalization rate for vaccinated Canadians remained at a low level throughout the Delta wave and is just beginning to rise with the onset of the Omicron surge. It is important to note that based on selected hospitals data up to the end of December, a majority of adults hospitalized with COVID-19 were people with severe COVID-related illness, while up to a third or more with COVID-19 were admitted for other reasons. Nevertheless, these trends clearly show that being vaccinated with 2 or more doses is highly protective. From early November to early December, when Delta remained the dominant variant in Canada, unvaccinated people were 19 times more likely to be hospitalized. As booster doses continue to expand, being up to date with COVID-19 vaccines is expected to preserve this protection advantage.
Slide 11. This updated longer-range forecast shows how the Omicron wave could evolve in the coming weeks as cases continue to accelerate across the country. It is important to note that this trajectory estimates the true number of daily cases as opposed to reported cases that may be occurring in Canada each day. Due to constraints on testing capacity, these numbers are much higher than can be detected. In fact, exceeds the number of cases reported in the surveillance data shown here as orange dots. The two scenarios shown on the slide, both of which incorporate the impact of booster doses, suggest that the Omicron variant could cause a large wave that may peak in January and then recede into February. However, it's important to remember that these are modeled scenarios and the timing of the peak is likely to vary across the country. The red line trajectory shows that without recent strengthening of public health measures in many jurisdictions, the Omicron wave could have peaked at about 300,000 actual daily cases. Whereas the blue line trajectory shows that with the recent implementation of stronger measures, we could experience a peak that is lower, with about 170,000 actual daily cases. These scenarios highlight that while combined public health measures and booster doses could help reduce the size of the Omicron wave, in either scenario, the true number of daily cases driven by extremely high transmissibility of the Omicron variant could still vastly exceed anything we have experienced to date during this pandemic.
Diapositive 12.
Slide 12. This updated modeling forecast looks at predicted new daily hospital admissions to help us understand how the exponential rise in cases could impact our healthcare system in the coming weeks. Assuming that the number of cases of Omicron follows the lower trajectory from the previous slide, given the recent implementation of public health measures in many parts of the country, this forecast shows two potential trajectories for new daily hospital admissions. The higher dark yellow line trajectory shows the potential impact on hospital admissions if the hospitalization rate for Omicron were as high as Delta. The lower blue line trajectory shows the potential impact of the hospitalization rate were 40% that of Delta, in line with emerging evidence of reduced disease severity in Canada and internationally. These scenarios suggest that even if we follow the lower forecast of cases and have a significantly reduced hospitalization rate for Omicron, the new daily hospital admissions could still exceed previous historical peaks, shown as the green horizontal dashed line, due to the sheer volume of true infections that could occur. It is important to note that this forecast reflects only new daily cases of COVID-19, new daily cases of COVID hospital admissions, not the total number of people who may be hospitalized with COVID-19 related illnesses on a given day. But regardless, we expect that this level of new daily admissions could result in significant levels of healthcare strain in the coming weeks.
Slide 13. Experiences of other countries that also experience an Omicron surge provide additional insights into how the pandemic may evolve in the weeks to come. Countries like the United Kingdom and United States that experience a sudden and very steep rise in Omicron cases also experience a sharp rise in hospitalizations. However, given the lower severity profile of Omicron, hospitalizations haven't increased at the same explosive rate as cases. Nevertheless, the sudden acceleration and enormous volume of cases associated with an Omicron surge puts an intense strain on hospitals over several weeks and adds to longer-lasting impacts, such as extended backlogs and strained workforce. With early signs that the surge in cases and hospitalizations may have peaked in parts of the US and UK, it is hoped that the heaviest impacts will soon be over in these countries. Likewise, if Canada's trajectory continues to follow a similar path, we are hopeful that cases will soon peak.
Diapositive.
Slide 14. While Canada could see a sharp peak and decline in cases in the coming weeks, given disease activity far exceeding previous peaks, even the downside of this curve will be considerable. With several weeks of very intense activity expected to come, we need to do our best now to limit the size of the Omicron surge in order to maintain the health system and critical functions of society. Practically speaking, we need to continue to get up to date with COVID-19 vaccines, including getting a booster dose when eligible. Limit mRNA vaccines from BioNTech and Moderna are effective booster doses, so trust in the vaccine that they are offering you on that day. Secondly, limit in-person contacts to immediate household members as much as possible, and consistently use layers of personal protections to reduce the risk of exposure and spreading the virus by following local public health advice, wearing a good quality and snug-fitting face mask, and maintaining good ventilation. Thank you. Merci, Miigwech.
Repeat the last slide, slide 14. So while Canada could see a sharp peak and decline in cases in the coming weeks, given disease activity far exceeds previous peaks, even the downside of this curve could be considerable. With several weeks of very intense activity expected to come, we need to do our best now to limit the size of the Omicron surge in order to maintain the health system and critical functions of society. Practically speaking, we need to continue to, 1, get up to date with COVID-19 vaccines, including getting a booster dose when eligible. Either the Pfizer-BioNTech or Moderna mRNA vaccines are effective as boosters, so please feel confident in accepting whichever vaccine is offered to you. Secondly, limiting in-person contacts to immediate household members as much as you can. And thirdly, consistently use layers of personal protection to reduce the risk of exposure and spreading the virus by following local public health advice, wearing a good quality and snug-fitting face mask, and maintaining good ventilation. So thank you. Merci, Miigwech. Happy to take questions.
Oui, donc on va passer au...
So we'll start from journalist questions. We have until about 12:30 maximum. Operator, up to you.
Thank you. For questions, please press star 1 on the device's keypad. Pour toute question, faites étoile 1 sur votre appareil. La première question nous vient de Raymond Filion.
The first question is from Raymond Filion from TVA. You have the floor. Question: with the progression of Omicron combined with vaccination, could Canada reach herd immunity? And if yes, when would Omicron become endemic?
Merci pour la question.
Thank you for the question. It's a little bit more complicated than that. With Omicron and the other variants, we know that for Omicron, we could have some immunity for some time, but it doesn't protect against other variants and virus strains. So it can help a little bit for some time, but it's not a long-term herd immunity. With vaccination, we know that they are very effective to protect people against severe illness, but with Omicron, we've seen it's not as good against infection and transmission. So it's difficult to say when we could reach herd immunity. It's really a matter of using all of the tools at our disposal in combination: vaccination and layers of protection, respecting public health advice. with this, we'll see in the next weeks and months what we need to do to find a balance to allow society to function well with a certain degree of transmission while avoiding mortality. So to do this, we need to use all of the tools at our disposal. Thank you. Follow-up question. I'd like to talk about third doses, the booster shots. Do you recommend that people who contracted COVID-19 get a booster as soon as they are done with symptoms, or should they wait some more time? Answer. This is a good question. NACI is currently studying the data on this. They're studying data from Canada and internationally. What I can say is this. If you're infected with Omicron, you get a little bit of immunity against Omicron for a certain amount of time, but we don't know how durable this protection is for a given variant, for example, Omicron. So if we want to give booster shots, if we do booster shots, we want to have a good interval to ensure a maximum immunity protection. With what I know, I would say that you could wait a few weeks after Omicron infection. But I'm truly waiting for experts to make recommendations on this front. So we're waiting for NACI's recommendation on what the optimal interval would be to get a booster shot after an infection. Thank you.
Thank you. Merci. The next question is from David Thurton, CBC News. Please go ahead. Your line is open.
Hi, yes, good morning. How do you model for COVID, Dr. Tam, when not everyone can get a PCR test? Is it a challenge, and how do you do it?
Yes, so on a local level, it is challenging because not everybody can get a test. But we are doing a lot of testing in the country. So, for example, some of the initial slides, you will see that over 150,000 tests are being performed from a laboratory testing perspective, which is a good number for the purposes of tracking trends. So we've reintroduced a slide on the laboratory positive rate, and that can be one of the indicators, along with others, that we use to see where this wave is heading. Right now, we're in a slightly sort of gray zone, if you like, of waiting to see what happens next. You can't tell whether you've really reached a peak, for example, until after the peak is truly over. And so I think in interpretation of the graphs that we're showing today, I just caution that last part of the graph, data that could be incomplete. And so we need to wait a little while to see if the trend continues on the downward trajectory. And as I've said, it's different in different parts of the country. But I think we're doing enough to appreciate the trends. But obviously, at the individual level, not everyone will know for sure whether they got Omicron. But the other rule of thumb we're telling people is that if you had your symptoms somewhere after December the 20th or thereabouts, you probably got Omicron, and essentially consider yourself in that group.
Okay, I'll just follow up, because you mentioned that, it's very hard to tell when this wave has peaked until it has peaked. We are hearing from Quebec's Premier, François Legault. He said that Omicron has peaked in that province. Is there any data that you've come across to support that statement?
Yes, and I think you can see a number of charts even in our data at the national level, which is a composite picture. So Quebec will have more information at their level. But first of all, most likely you'll see the cases peak first before the hospitalizations and the ICU admissions. So you're seeing that pattern in the national picture. So the national picture is because Ontario and Quebec drives the national curves, given the size of the population, and they were the first to experience this Omicron surge. That dip in the case curve is perhaps indeed the trend, but we just have to wait a little while to be able to confirm that. The other thing is that even if a curve comes down, it can always go up again, depending on the context within a population. For example, as people go back to school and work, those cases could come back. So it won't be necessarily a smooth curve downwards. It could be a series of bumps. So we will likely be able to discern that at the national level as well.
Thank you. Merci. The next question is from Boris Proux, Le Devoir.
Boris Proux, Le Devoir, you have the floor. Hello. My question is on slide 12. On predicted hospitalization. In your presentation, you talk in the future tense or the conditional tense, so we could see an increase. So here you present the situation between January and February. As far as I know, we're right in the middle of this period. Have we reached the peak in this graphic? My question is this. Would you say we're in the blue scenario with a hospitalization rate that is lower compared to Delta, but that exceeds the highest hospitalization rates? Answer. Thank you for the question. It's difficult to say because with modeling, it's based on the data that we have at the time. It's not a crystal ball. Our destiny is in our own hands, really. I think that if we follow the trend with the current public health guidelines in place and increased vaccination rates, it's possible. We can see a lower rate of infection, which would be a late indicator, would show a lower hospitalization rate. So it's hard to say what will happen. So we have to follow the data closely, the case counts, and the hospitalization rates, even admissions to ICU. And that way we can see what the effects are on the healthcare system. Question. If I understand your answer, we would need a crystal ball to understand how things are currently. I'm going to ask you a very specific question. In Montreal or in Quebec, we're saying that we've passed the peak of a case increase. So we're saying that currently the peak increase of COVID-19 cases has been reached. Do you believe that? Answer. We don't have a crystal ball. No one has one. None of the public health authorities have a crystal ball. So it's difficult for me to speak to what's happening in Quebec because public health authorities in Quebec have the most precise data, especially compared to what we have here federally. So if public health authorities in Montreal and in Quebec are watching the trend and seeing that new cases are going down, it is possible that the peak has been reached. It's possible that in a few weeks we'll see case numbers go down and the hospitalization rates go down as well. We know that normally the proportion of people infected with COVID-19 will a given proportion of people with COVID-19 will need to be hospitalized. It could be optimistic to see that if we have a reduced case number, if this trend continues, maybe we'll see an impact on hospitals, but it's hard for me to say. I think it's really better to turn to public health authorities in Quebec to ask about that.
Thank you. Merci. The next question is from Abigail Beeman, Global News. Please go ahead. Your line is open.
Hi there. Thanks for taking my question. As you note, several provinces are starting to give more detailed data on hospital admissions. Using Ontario as an example, we now know nearly half of people included in COVID hospitalizations were actually admitted for another reason but tested positive. I'm wondering if this is the first time you're including that national look of people who were admitted to hospital because of COVID versus for another reason. What benefits or drawbacks do you see in this kind of reporting? And also, does it suggest hospitals may be less stretched compared to a non-COVID regular year now that we have this additional information?
Yes, Teresa Tam. So as you said, many jurisdictions are now trying to discern whether someone is hospitalized because of COVID or that they also have COVID and they're admitted for something else. I think that's useful in the study of the impact of the Omicron variant, but for the hospitals themselves, they are pretty full, and hospitals have always been very stretched during the winter months in any case. And so this really doesn't help at all, having a massive Omicron surge. What I'm seeing is that even if you say, so think of only a proportion of cases in the hospitals directly because of Omicron, the numbers that I'm seeing of hospitalizations being reported, even if you have that, it's still much higher and getting that to be higher than the other peaks that we've seen in the other waves. That's just the comparison. So even if only a proportion of them are there because of Omicron, it's still a huge number of cases. The other parameters that we are trying to discern from the provinces is the length of stay and then also the clinical progression inside the hospitals. So far, what we've been hearing is that the length of stay seems to be shorter for the Omicron variant cases that we're seeing after December, and also that for the ICU admissions, there seems to be less of those, but still over 884 daily critical care bed use is huge. So that, I guess the bottom line is this variant is having a very significant impact on the hospitalizations. But the other thing that's very different is that, of course, staff are getting sick at the same time. So that is putting a lot of pressure on the hospital systems.
It's Dr. New. Maybe I could just add one additional point, and that's the fact that, we are teasing out with obviously our counterparts in the provinces and territories in terms of hospitalizations. They say, because of COVID-19 or sort of just an incidental finding if someone sort of went to hospital for another reason, maybe elective surgery and so on. But the bottom line, really, if you're on the ground, is that it still has a tremendous impact in terms of the strain on human resources, because if you do find it as, quote, an incidental finding, someone with COVID-19 in the hospital setting, the staff, et cetera, you have to take other precautions and the measures, et cetera, to try to prevent, obviously, onward spread. So, like I say, even if, it's not a direct impact in terms of having to deal with a COVID-19 case that is in there because of serious consequences because of the virus itself, there's still obviously a knock-on effect in terms of the impacts of just finding, the COVID-19 the virus with other admissions to the hospital. So overall, as we've been repeating, the strain on our healthcare system is tremendous, and I think as much as we can do, all of us individually, collectively, to decrease the pressure on the hospital system, our exhausted healthcare workers on the front line, I think that's really what we need to be focusing on. Thank you.
Thanks, that's really helpful. I also wanted to ask about the information in your notes about children, infants being 7 times more likely to be hospitalized than children under 5. I'm wondering if you can shed more light on what we know about infant and under 5 hospitalizations. Is this higher or different than in previous waves? And also, do we know whether these infants and young children, generally speaking, have other underlying conditions?
Yes, thank you for the question. So the rates are still low in children, but because of the massive number of cases in our communities, we do expect the actual numbers to be higher than in preceding waves. So I think that was expected, but the absolute numbers are still quite low. We've been checking in with a network of all the pediatric hospitals to ask them what they're seeing. And so in general, the cases are not very severe, but of course severe enough to be hospitalized. Infants, no matter what respiratory virus you get, are likely to be more severely impacted. And so I think that's not unusual. So any infants under 1 year of age often experience more severe outcomes from respiratory viruses. So there's a number of, I think, important things to consider for kids, of course, to protect younger children, especially because they're not eligible for vaccines. The adults around them and the guardians need to up the game in terms of getting themselves protected through vaccinations and boosters and masking and all the other layers of protection to protect them. But one other really important point to make is vaccination during pregnancy. So this is very important for protecting the individual who's pregnant, but also the infants, both of whom are at a higher risk of severe outcomes. So vaccination with a mRNA COVID vaccine is strongly recommended, and research shows that vaccination during pregnancy triggers the development of protective antibodies that can also be passed on to that young infant and provide that infant with a level of protection.
Thank you. Merci. The next question, la prochaine question est de Raphaël
Raphaël Pirot, Agence QMI. The floor is yours. Question. I would like to ask you about the geolocation data collection plan. I would like to know what public health is doing with this data. Specifically, why are geolocation data collected for modeling? Answer. Thank you for the question. I can start and maybe Dr. Tam can jump in. I first would like to say that we take confidentiality and privacy seriously. It's very important. When we collect data, it's population-wide. We're not collecting data on individuals. It's used as a tool to help us assess public health measures. It helps us see if case numbers rising can be associated with population movement. Generally, this is what we're using it for. But we also make sure that our data collection is not individual personalized data. Thank you. Second question on another subject. In Spain, public health has put out a call for Omicron to be considered a regular flu. That's what I'm understanding public health there is proposing. People are reacting strongly. Could we say the same thing here in Canada? What do you think of that? Of course, we're talking about saying this after the peak of Omicron has passed. Answer. Thank you for your question. I think it's a little early to say whether or not the situation is similar, whether the situation with Omicron and COVID-19 is similar to the flu. We can see that with hospitalization rates and mortality rates, we can say that there's a lot of pressure on our healthcare system. Certainly after the Omicron wave, we'll be able to see what the next steps are for vaccination and other public health measures. We will always make decisions based on science and data before moving to next stages. For now, we're still in the thick of it. And we need to react now to the current situation. Later, we'll see what we do and how we use all of our tools to fight COVID-19.
Thank you. Merci. The next question is from Marika Walsh from the Globe and Mail. Please go ahead. Your line is open.
Hi there. Thanks so much for taking our questions. I wanted to go back to what Boris was asking earlier about the peak, because looking at the slides, it quite clearly shows the wave that's being projected and modeled is that we're essentially in the peak now. We're about to hit the peak for hospitalization, and that we've already hit the peak for cases. And then the slide title says a surge is coming in the next week. And so I'm just confused about what you're saying. I understand that you can only say with certainty that we've hit the peak after it's over, but it seems to be showing based on the data that you actually do believe that we are now at the peak based on the available data. Is that correct or is that incorrect?
It's Teresa Tam. I'll take that question. I think the next week is actually quite important. We received a number of questions today about, well, in certain local areas, have they reached a peak? What about Quebec? I think a number of provinces, the biggest ones, put it this way, who have particularly experienced the Omicron surge the earliest, are seeing some stabilization at a very high level, but some stabilization in the daily case rates. So I think this is the early signal that we could be approaching that peak. All I'm saying is that there's a gray zone or a zone of uncertainty that you're seeing in either the projections, but also in the actual case trends. So I think come back in about a week, we'll probably have a little bit more information as well. But it is quite possible that in the next days that we'll see that peak, at least in the cases, the hospitalizations. What I would say is that what the modelers did is that they inputted certain assumptions, like how many days after a case declares itself would they get hospitalized. Those assumptions may or may not be completely aligned with reality and the range. So you're seeing that uncertainty being depicted. I think the models are there to, I guess, assist with planning purposes in terms of whether it would exceed previous hospital intake. And so I think all of this, though, does align together with the international data to say that we could be like others, seeing a sharp increase and then it coming down fairly fast. But I think we're all just wanting to be cautious about pronouncing on that until we've seen more information.
Okay, thank you so much for clarifying that. I also wanted to go back to your comments at the beginning where you said that if you had symptoms on or after December 20th, assume you had Omicron. Earlier this week, we saw Alberta say that they believe their actual case count is 10 times higher than the reported number. What is PHAC's estimate of the true case count in Canada? Is it 10 times higher across the country, or what is the sort of guesstimate that you are working on?
Well, I think if you see one of the forecast curves, you see those little orange points. is the actual number of reported cases through surveillance. Our previous models, the little red dots or other plots that we've had followed the projections pretty well, and now it doesn't really. So I think the number of cases are likely to be much higher. But it could be different in different provinces. We've seen that even with the other waves, where in fact, Canada was quite good at capturing most cases, and we backed it up through sero surveys, where we look at antibody levels. Yes, you only get the tip of the iceberg, but we got quite a large tip of the iceberg compared to maybe some other countries. Right now, I can't tell you at the national level what that means. I think the sero surveys that will be conducted over time, particularly, I think, at the end of this wave, will tell us maybe how much of the population did get infected in the end. But I do think that it could be different in different jurisdictions, and some of it might depend on their capacity for testing at any given moment.
Thank you. Merci. The next question is from Alex Ballingal, Toronto Star. Please go ahead. Your line is open.
Hi, thank you very much. Just on testing, we've heard from some experts questioning whether, given the prevalence of Omicron, testing capacity in the provinces, how we don't know the actual true number of cases, that it's making less and less sense to put so much resources into testing incoming travelers. So I wonder, Dr. Tam, what you think about that. Is this Omicron wave different, and does it still make sense to put, I don't know what the budget is, I think it's $600 million towards testing people coming into the country?
Yes, so as you say, in the domestic sense, tracking every case isn't really necessary for a surveillance perspective, but while it may be important for certain individuals, I think at the border, it's not just Omicron-related detection that we are trying to do. We're there also to detect any other new variant or mixes of variants. But at the moment, when the whole world has Omicron, our next door neighbor has Omicron for the most part. You're right in that we could do sampling for the tests instead of testing maybe every single vaccinated individuals coming from other countries. But we will evaluate that over time. It is a capacity drain on the systems as a whole. So we've been trying to look at that and balance it out. At the moment, of course, we are continuing the trajectory that we have laid out in terms of traveler testing, but we should evaluate that over time. But what is really important for the border is a really good random sample where you are not just following Omicron, but following the other variants.
So just to clarify, so have you brought that up in your advice, that this is maybe something where the resources being put to use could be better utilized elsewhere? Is that something that you guys are actually looking at, changing that practice?
I think we're always evaluating this with our laboratory colleagues, and we haven't as yet had to make a shift. But if necessary, I think we would consider it. There is, I think, for the sequencing though, it is something that we are looking at, because you don't have to sequence every case anymore. It is all Omicron. So we were sequencing every single traveler. We don't think that is actually needed or viable. The genomics capacity can be utilized in different other ways. There's also staff absenteeism and other things. So I think my advice would be not to have to sequence every single traveler case.
Thank you. Merci. The next question is from Ryan Tumulty, National Post. Please go ahead. Your line is open.
Yeah, I'm wondering, Dr. Tam, you talked a little bit about estimates of how much the cases actually exceed the publicized daily case count and some of the other assumptions that you are making. I'm wondering how you're making those assumptions. Why do you assume that the case levels are that much higher than the testing? What data is driving you to that conclusion, I guess?
Well, I think partly it's just the indication from our colleagues, the other chief medical officers, that they're simply not able to test every case. So you know that to be true. That's a fact. And also anyone who did a rapid antigen test, for example, that's not captured through for the most part. Some jurisdictions are trying to do so, but a lot of it is not captured through the provincial system. So we know that we're missing that part of the part of the iceberg, if you like. So, and as you've seen from the reports from the other chief medical officers, they're quite clear that they're not going to track every case. We've moved on from individual case contact management as soon as this resurgence became very significant. So you don't need that for the population level management. You're moving towards the broader messaging, and you can't trace every contact, etc. So we know that to be true. And is this even with the other ways, as I said, in retrospectively looking at the serologic surveys, we know that we only detect the tip of the iceberg. Now the lab testing capacity, rightly so, is directed towards those most at risk. And it would be very important, of course, to direct things like treatments. People are looking forward to antiviral treatments, for example, and you need to make sure that the tests are directed towards those. So there is no doubt that we underestimate the cases. Having said that, though, our focus of attention should be more looking at the hospital trends and the severity indicators. The case trends gives you a signal because it's the earlier signal than the lagging indicators. But really, we have determined, and I think there's a slide that shows you the characteristic of the Omicron virus, one of which is that, really you want to be tracking hospitalizations, ICU admissions, because that is where our public health action and healthcare action is going to be. And also that the vaccines themselves, the most important aspect of the vaccine effectiveness is tracking its effectiveness against severe outcomes.
I guess just as a follow-up on that, I guess I'm sort of wondering, though, how I understand that cases are definitely higher than what's being reported. I'm wondering, though, how you estimate how much higher, and how you mentioned at one point that you think there may be, at the peak of the wave, somewhere around 170,000 cases a day. I'm just wondering, how do you decide what the multiplying factor is there?
Yeah, and I think there's different models being used, and some of the details might be in the annex, but some of it is taken into account other parameters such as transmissibility, the R value that you've all got a bit used to, and comparing Delta to Omicron and factoring some of those elements in, as well as there's many other injects into those models, including booster dose uptake, etc. So I think it's quite a complex, composite of inputs in order to generate those curves. But those are the estimates that's been generated by the modelers to give people a bit of an idea of how high those case counts could be.
Thank you. Merci. The next question is from Laura Osman, the Canadian Press. Please go ahead. Your line is open. Once again, Ms. Osman, you might be on mute.
Pardon me. Sorry about that. Thanks, doctors. I wanted to ask you about the data. Dr. Tam, you said that tracking every case isn't necessary for good surveillance necessarily, but it's clear that from slide 5 that we're losing some of the more granular data. I'm thinking particularly of data involving how much this is impacting kids. A lot of the public health measures are disproportionately affecting kids. You know, schools are closed, recreation is closed. And so how do you make good decisions, and what are your fellow chief medical officers saying about how you make decisions about whether or not these measures are working when the people they affect most are not being tested?
Yeah, and I think there is a lot of testing, and there's probably enough testing to look at those trends. So you can see the disaggregation by age and how those are trending, and the shifts over time between the younger adults, and then really the spread of the cases into the other age groups. So that is actually quite easily detected and can be trend using surveillance data at this point. We're doing like 1 million tests a week, over 150,000 a day. So that I think presents a reasonable data set. But we do pay attention when the policies suddenly shift. And that's why I think looking at the composite of all the different indicators is important. The other thing is ultimately the hospitalization rates are important to track. And those tend to be, quite comprehensive in terms of the numbers of hospitalizations, so that you can have a greater certainty about. I think that this aggregation that's happening to further understand who is being hospitalized because of COVID, who is having their underlying medical conditions being made worse as a result of COVID, are all very important. But it is quite easy for us to use hospital surveillance networks to trend the hospitalizations in pediatrics and the pediatric ICU admissions, for example. So I don't think we will lose track of the ability to detect any significant change in those parameters.
Thank you. On hospital cases, nurses have flagged that the number of people in hospital with COVID who are there for other reasons may be reflecting in-hospital transmission, and they're really concerned about that. Is that something that you're seeing in the data, something that you're particularly concerned about?
Yes, so again, I think the details will have to be obtained from the local jurisdictions. But yes, there's in fact different categories of cases that are hospitalized, some of whom actually did acquire COVID as part of a acute care outbreak. So those are happening. Those outbreaks are being tracked. And it could be due to a number of factors, sometimes as to what the dynamics are in terms of the spread in healthcare settings. But it really does continue to stress the need for good infection prevention control practices. But it's been very, very difficult. I mean, I think healthcare workers, no matter how hard they try, like the rest of the population, in minimizing their risk, this is such a transmissible virus that we have to all up our game everywhere, including mask wearing, etc., ventilation and everything else in order to reduce those risks. So, but yes, healthcare setting related outbreaks are something that we should do everything to try and minimize.
Thank you. Merci. La prochaine question est de
Marie Chabot Johnson from Radio-Canada. You have the floor. Thank you. If we're still unable to say that the peak has been reached for Omicron, I understand we're still uncertain about the data. Should we still maintain public health measures until we have a better idea? There are places in Quebec, for example, that have removed the curfew. Answer, this is Dr. New. I had some challenges hearing you. There was some echo on the line. But if I understood the question correctly, the answer is yes. This is the challenge for public health authorities and deciders in places like Quebec. We have to follow the data. And we also have to connect it with public health measures. It's really not up to me to say what Quebec is doing with their data or what their public health decisions should be. You talked about a curfew. What I can say is that I understand that in Quebec and any other province or territory, it's very important to understand what the impacts are on hospitalization rate as an indicator. Also have to take into consideration the number of cases in a province. Right now, we're seeing authorities are maybe seeing a plateau or that the number of cases is going down. Maybe then a few public health measures can be loosened, but it's really up to the authorities to make these decisions. It's always important to remain flexible and to adjust our approach as the epidemiological curve changes direction. Question. We've seen that Canada is going to enforce regulations for international truckers and vaccination. Can you tell us what the impacts might be on this? Answer. The goal for public health in Canada in general is always to increase our vaccination rates. Canadian truckers are part of our general population. They're part of society. And so I think it's very important to encourage them to get vaccination for truckers and the entire population. We know that there are challenges and there could be impacts on this sector like any other sector. But I think generally, regardless of sector, we have to continue using all of the tools we have, including education, to increase vaccination rates. Current data is showing us clearly that vaccines are safe and effective in protecting people. And vaccines protect us against contamination, but also against severe illness. It's also a way of protecting people around us and our communities. So definitely, we aim to increase vaccination rates in general.
This question is for Dr. Tam. You've already mentioned a few times that healthcare systems across the country are having a very difficult time. New Brunswick brought in new restrictions today because of concerns about its own healthcare system really approaching a crisis. I want to know, in practical terms, what do provinces have to prepare for when they look at the forecast for hospitalizations, even at the low end here with, say, 2,000 cases of new hospital admissions daily? You know, are we concerned about overflowing or tapped out ICU resources? Are there enough, intubation and respirators, let's say? You know, what practical impact will these forecasts have on healthcare systems across the country? What do provinces need to prepare for?
Yes, and we're obviously not the only ones doing forecasting. It's being done at the provincial and other levels as well. So it's always better to prepare and prepare ahead for the worst case scenarios. I think this is not the first time we're going through this, and it's very important to have approaches to look at how you can continue your acute care system. And many jurisdictions, of course, have tried reducing elective procedures, having surge beds, even building, additional beds and field hospitals, and all of that, it has been in their preparedness scenarios that's already been done. Obviously, we've been looking at supplies. There's definitely enough ventilators. The ICU rate isn't going up as high as the hospitalization rates. So looking at that very carefully is important. We are sharing information on length of stay and that type of thing across the jurisdictions, because that's really important to know how long someone stays, because that has a significant impact on how you project your hospital capacity. So all of that information is being shared across federal, provincial, territorial tables to inform the provinces that might be coming a little bit later than the initial ones. So those have been, I think, the most practical ways of doing this. But the other thing is factoring in staff absenteeism. So I think that's almost the most difficult rate limiting step for jurisdictions right now. And as a result, they are doing more population-based measures to reduce contacts, because it's not just about getting enough beds, it's about getting enough human resource and protecting the healthcare workers in their communities.
I'll just take a follow-up question here. Can you give us an estimated percentage of cases? I know that testing isn't exactly as widespread as it once was during this pandemic, but is it safe to assume that all of these new cases are Omicron, or is Delta still making up a percentage of the cases across the country, or even other variants?
Yes, so right now, we don't really need to sequence every single case. As I've said, you need a sample of them, and the vast majority are Omicron. At the same time, there's always a very small number of other genomic sequencing that we're detecting. But right now, the Omicron variant is absolutely the majority, and that is being seen in every jurisdiction now.
Thank you. Merci. The next question is from Dylan Robertson, the Winnipeg Free Press. Please go ahead. Your line is open.
Good morning, doctors. I'd like to discuss incidental COVID-19 in hospitals, as it seems that this is not being consistently reported by the provinces. Are you providing any guidance to medical officers on how to parse primary versus incidental infection? And is SPAC recommending provinces do this analysis, or is the value of this data totally at the province's discretion?
It's Teresa Tam. So this is an actual technical area that we've discussed in our federal, provincial, territorial tables at the SAC and the chief medical officers and our technical groups. So provinces, it is definitely the most useful for the provinces. At the same time, at the sort of national level, it is still useful for us to know that parameter. I think that the difference between the Omicron and other variants is that it's just so pervasive that you could very well come in because of something else and you have Omicron. So that's the slight difference between this variant and others. And I think sometimes it does help with local level planning, but it's much more important for provincial levels. But we are sharing how the methodology, put it this way, of how provinces are trying to discern that difference. And the way that they try to disaggregate that information varies as well. And a lot of effort has been put in. Some of it is an actual manual case review. That's how much effort it takes to get at that information. Now, once you know, you have a bit of an estimate. I'm not entirely certain that it's worthwhile just keep doing it all the time, but that's up to the local jurisdiction to decide. But we are sharing the methodologies on how that is done. And as I've just said, some of it is also disaggregating the ones acquired inside the hospital as well.
Thank you. And Dr. Tam, certain provinces say it's up to individuals to protect themselves from COVID. They're abandoning attempts to limit the spread and instead focusing on avoiding the worst outcomes. But is it actually possible for everyone to protect themselves given the disparities that you've reported on in public health?
Yes, so getting equitable access to layers of protection is always a concern. So I do think that at the federal level, one of our roles is trying to, as I said, level the playing field as much as we can. So I think having social supports is important. Some of the policies in terms of supports to individuals at the lower socioeconomic strata or small businesses, and that's not within our realm of policy decision making, but it is very important. And of course, one of the federal roles is to support Indigenous communities, and I believe Indigenous Services Canada had provided an update on some of those measures as well. We're also concerned about the distribution of rapid tests to those who may have needs but can't access. So through the Red Cross and mechanisms and other NGOs distributing rapid tests. And I actually think distributing good, high quality masks, for example, to populations experiencing equity disparities is actually important as well. It is of course, certain workplaces, I think making sure that employees who have to be on site to work, unlike a number of us who can telework, is also extremely important, and making sure that they have everything that they need to protect themselves.
Thank you. Merci. The next question is from Wyatt Sharp from the Wyatt Sharp Show. Please go ahead. Your line is open.
Hi there. Just one question to start off as it relates to COVID treatment, specifically Pfizer's pill to treat COVID. Obviously, it's not yet approved by Health Canada. I'm just wondering, though, if it does get approved by Health Canada, what kind of an impact that will have on, for example, future modeling, like the modeling you presented today, what kind of an impact that could have on future hospitalizations, and if you even have a sense of that yet.
Yes, so for modeling purposes, it could be something that we can factor in. The benefits of Paxlovid, as demonstrated through clinical trials, is to reduce severe outcomes like hospitalizations in those at high risk. Those initial clinical trials were done in unvaccinated populations as well. Once we get a medication, trying to get some data on its impact post-authorization is important, and those kind of data will help inputs into models. So one might postulate that a model that estimates X number of cases could end up in a hospital. Well, if you had a treatment that could prevent some of that, that can potentially be factored in, but I think this is a little too soon. I think Canada is fortunate in being probably one of the first countries in the world to access these medications, but there is a global supply constraint. It may not be in widespread use for a while. So I'm not certain when that would be significant enough to factor into the model. But I think overall, if we do see the proportion of people who get COVID and the rates of hospitalization, that's still an important indicator to trend over time for sure. But not just now, but I think later on it could be factored in.
And is there enough evidence yet to show which people would best to give this treatment to? Because you just mentioned that if it does get approved by Health Canada, there will be limited supply of it. So is there any idea of, once it does get approved, should be prioritized, or is that just, once again, something else that's kind of just remains up in the air up until it is approved by Health Canada, and if?
Well, I think we're trying to line up all of the different tools and supports provinces might need to help them with implementation. So I think what we're trying to do at the Public Health Agency is to convene experts to help provide some considerations as to how the initial supplies could be prioritized, much as we did at the beginning of getting our initial doses of vaccines. So that work is underway as well.
Alors, c'est ce qui met fin à cette conférence.
This brings today's press conference to a close.
Have a great weekend, everyone.
Thank you.